Hello, everybody. My name is Christoph Correll. I'm professor of psychiatry and molecular medicine at the Zucker School of Medicine at Hofstra Northwell in New York. And I'm also professor of child and adolescent psychiatry, Charité University Medicine in Berlin, Germany. I'm interested in psychopharmacology, early intervention, as well as physical health and mental health. And I'm pleased to be able to present to you my view on the data that exists for early onset schizophrenia. I also want you to please participate in our, what we believe, worldwide largest study on the impact of the pandemic in the general population, adults, adolescents, and children. The COVID study, collaborative outcomes study on health and functioning during infection times. Almost 170,000 people from 155 countries have participated. We need more, less than 5,000 in the US. www.cofit.com with or without the hyphen, www.cofit.com. This is my disclosure information. I'm fortunate to work with a number of companies that are still operating in the brain. As you know, many unfortunately have left because it's so difficult to beat the placebo effect and then also to get new medication to market, which in adults then means that we finally will get them hopefully also approved in children and adolescents, at least studied due to the mandate by both the FDA and the EMA. I'll briefly touch upon the characteristics of youth with schizophrenia and then focus a lot on treatment. This is from a meta-analysis of 193 studies that we just published in Molecular Psychiatry, just reminding ourselves that by the age of 14, a third of all mental disorders have been diagnosed. By the age of 18, it's half. And by the age of 25, it is 62%, almost 2/3. What about schizophrenia and psychosis? Here, the numbers are smaller. Before age 13, that is mostly prepubertal, 2%, that's 1 in 50 adults with schizophrenia. Looking at prior to adulthood, so by the age of 18 until age 17, it's 8%. That's still every 12th person who is diagnosed with schizophrenia as an adult will have had the onset during childhood and adolescence. Actually, when you look at psychosis spectrum, people might avoid the schizophrenia diagnosis. It is still 1 out of 8 people, 12%. But then by the age of 25, half of the people who have schizophrenia lifetime will have been diagnosed already. So schizophrenia is an early onset condition which has serious implications, which is why we need to identify it early and treat it early and treat it as well as we can. So we just talked about early onset schizophrenia, very early onset schizophrenia. It could be 13, it could be 12 as a threshold, is generally considered prepubertal. There, the numbers are much smaller. The ratio between male and female is 2:1, particularly before the age of 18. And we also know, as I will show you, that although kids live with teachers, live with families very closely, the duration of untreated psychosis is actually much larger, 3 times as large in children and adolescents than in adults. So we need to really pay attention to the emergence of psychosis, not disregard it, not misinterpret it as like a difficult adolescence or substance-related difficulties. We also believe that the early onset may be associated with poor outcome. And we'll see some of the data for treatment-resistant schizophrenia in a minute. But it's important to actually pay attention to these children and adolescents so that they can catch up and don't lose developmental milestones, both in terms of behavior, socially, but also cognitively. We also know that early onset patients are usually more sensitive to side effects, and we'll talk about that also. Now, diagnosis can be difficult because adolescence is a time, childhood too, where other psychiatric disorders emerge. And this emergence may have overlapping symptoms that we misinterpret or that make it hard to identify true emerging schizophrenia, especially when people hide their symptoms or minimize them. We need to be mindful of the overlap with mood disorders, also recognizing that depression is often part of the prodrome to full psychosis. There can be developmental differences. What is normal or abnormal imagination of an imaginary friend or misinterpretation of stimuli or ideas? Trauma is certainly something that can give rise to psychosis, even intermittently. Same with stress and anxiety that can mimic psychotic symptoms. Is it a hallucination or an intense preoccupation? What about schizo-obsessive symptoms when people have emerging OCD? Also, pervasive developmental disorder, autism, can make it difficult to fully unravel the both formal and content aspects of thought. Aggression, could it be hostility or psychosis? Depression or negative symptoms? And often there's an inexperience with diagnosis or reticence to actually give that diagnosis. We know, though, that people with early onset psychosis before age 18 have a harder time to have good psychosocial outcomes, because often there's also a neurodevelopmental pathway into the disorder, making it very important to diagnose patients early. When looking at a GAF score of less than 50 as a poor outcome, you can see that early onset schizophrenia has 60% of people with a poor outcome compared to 47% when you have other psychotic disorders mixed in. Having more males also gives you poor outcome in 56% versus when there are less than 50% of males, 39%. So here again, we have the subgroups of males and full schizophrenia diagnosis as having a poor outcome. I mentioned it already. In studies that we looked at that had the same methodology to diagnosing and determine in DUP, duration of untreated psychosis, it was less than 6 months in adults, and it was more than 18 months in youth. Thus, we really need to educate and also pay attention to signs and symptoms of psychosis. There was a lower rate of comorbid substance use, but it was still almost 50% in youth samples that already had a mean age of 16 years. But this goes from half to almost 2/3 of people with substance use comorbidity in adults aged 23 and a half on average. It's not rocket science to know what predicts poor outcome. It's basically poor baseline symptomatology, whether it's positive symptoms, more negative symptoms, and particularly also more premorbid adjustment problems. We need to pick that up and focus a lot of our psychosocial and pharmacologic attention to these subgroups of patients that may have a harder time to respond and to have good functional outcomes. This is a complex slide. I only want you to look at the top line where you see most of the cells, that is individual studies, are dark. And dark means that this one predictor was significant in each and every of the study except for one. And that was younger age of onset being a predictor of treatment-resistant schizophrenia. All other predictors that are listed below, almost 30 of them, were only splattered in one or another study. So we have in child psychiatry a subgroup that is more likely to be treatment resistant. That will inform treatment. So let's talk about that. You know that I know that you know that medication is only part of the parcel. We need to give wrapped around care that has psychoeducation and psychotherapy flanking medication treatment. And you also know that efficacy is just a spearhead of the treatments, what we need to look at. Yes, we need efficacy, but rarely is that defined just by a symptom improvement as done in clinical trials. We need also tolerability, because otherwise patients will not take it and not adhere. But what we really want is higher order outcomes where efficacy and tolerability become one merged element, and is subjective well-being, quality of life, and especially functionality. But there's no functionality without symptomatic stability. But symptomatic stability alone will also not suffice. We can't have people being cognitively impaired by too much EPS, by too much sedation, being incapacitated, and we also need psychosocial rehabilitation. Therefore, psychoeducation is important, stress management, sleep hygiene. Patients should stay away from illicit drugs and alcohol. Support groups in psychotherapy can help. School and vocational interventions are important, and CBT for compliance can be helpful. Side effect and symptom charting as well. But this is more a consensus-based approach, because in child psychiatry, there are almost no randomized trials looking at these interventions. Here we have a meta-analysis of 10 studies that looked at early intervention, that is integrated care of psychosocial and pharmacologic treatments, with some studies going down to the age of 16 in these early phase psychosis patients. So this doesn't entirely apply to child and adolescent psychiatry, but it at least gives us a good hunch of what's going on. And what we were able to display here and show is that out of the 15 outcomes that we were able to meta-analyze, all 15 of them were in favor of the early intervention service that had psychoeducation, group and individual psychotherapy, family intervention, case management, and or supported employment and education wrapped around the core treatment with an antipsychotic. So what is the efficacy of our antipsychotic treatments? First of all, which agents are approved and should be discussed in our algorithm, particularly because the approval is based on a randomized controlled trial that was better than placebo in favor of the antipsychotic. Here, approval for aripiprazole in the United States, lurasidone, olanzapine, paliperidone, quetiapine, and risperidone, all age 13 to 17, with the exception of paliperidone that started at age 12. Clozapine doesn't have real FDA approval, but is obviously the standard of care in adolescents and therefore grandfathered in. Here's an overview of the randomized controlled trials, always against gray placebo, the gray bar being placebo. And you can see that placebo shifts based on the trial and the population, as does the medication effect. So what we need to do, and I'll show this to you in a minute, is also randomized controlled trials that are pooled meta-analytically to look at the delta between the treatment and the placebo. Initially, the FDA allowed flexible dosing, 2.5 to 20 with olanzapine. Then they required fixed dose studies, 10 or 30 of aripiprazole, also better than placebo, like olanzapine, 1 to 3 milligrams or 4 to 6 milligrams in a dose range fixed study with risperidone, which may mimic clinical care better because you have some choice within each dose range. Then there was a pseudo-placebo trial, 0.15 to 0.6 milligrams of risperidone, behaving like placebo, versus 1.5 to 6 as a flexible dose. 400 or 800, better than placebo with quetiapine. Interestingly, when weight-based dosing was used in paliperidone as well as ziprasidone, there was not an effect for ziprasidone and only for one combined weight-based dosing group with paliperidone. But when the weight-based dosing was taken away and each dose was analyzed separately, then even with paliperidone, the active groups 3, 6, and 12 milligrams all separated from placebo, telling us that most likely small people don't necessarily need small doses. As in big adults, we would not double the dose that we give to a usual 100 or 140-pound person. Therefore, start low, go slow, but go, and using the whole dose range should be recommended, also with antipsychotics in children and adolescents. Another point, in fact, is asenapine. Here they went with 5 milligrams instead of 10 as a lower dose in children and adolescents, and that dose was not significant. 10 just made it, but the statistical plan pooled the two doses together, and so there was no approval. Had they used 10 and 20 milligrams, this would have worked. So again, use the right dose for the right person. Lurazidone, 40 and 80 milligrams, here significantly better than placebo. Who responds best? This is a study where we actually looked at subgroups in this lurazidone study of those that were totally treatment naive, had never been on an antipsychotic before. And here you can see that the effect size at week 2 is 0.6, which is double the effect size in previously treated patients who were washed out from the antipsychotic, somewhat more chronic, even though they are still young patients, where the effect size was only 0.3-ish. And then at the end of 6 weeks, it's again, instead of 0.45 effect size, which is still respectable, a 0.75 effect size. Earlier use, most likely better efficacy. But we also need to keep people then on treatment if they truly have schizophrenia to avoid relapses, because a relapse can then diminish further efficacy, as we can see here in the previously treated patients, and as has been shown in adolescents and in adults. Head-to-head studies are much fewer and farther between, very small n. The only difference that is in head-to-head studies available and visible was really with clozapine versus haloperidol in treatment-resistant patients, or clozapine versus regular dose olanzapine, or high-dose olanzapine with 30 milligrams as the upper dose. Other than that, no big differences. Side effect differences in children and adolescents with antipsychotic treated who have schizophrenia, most likely much larger than efficacy differences, similar to people that are adults with schizophrenia. There were two larger studies. One was comparing paliperidone versus aripiprazole. No difference in the efficacy, comparing 6 milligrams of paliperidone as the modal dose versus mean dose, or the modal dose was 15 milligrams of aripiprazole. Mean dose was 7 for paliperidone, 12 for aripiprazole. Similarly, in a study we conducted in Denmark, no difference comparing aripiprazole with quetiapine extended release in any of the PANSS scores. And this was 450 milligrams mean dose, again, versus 15 milligrams with aripiprazole, the 450 with quetiapine. And the target dose of 600 milligrams with quetiapine or 20 with aripiprazole was reached in 3/4 of the patients. We then performed a meta-analysis, a network meta-analysis, comparing non-clozapine antipsychotics, because we felt adding clozapine in would mix treatment-resistant patients with non-resistant patients. What did we find? We found in green that all of the agents were significantly better than placebo, except for what we had seen in the individual study, ziprasidone and asenapine, with effect sizes that are respectable and very similar to what is seen in adults, which I listed on the right-hand side from a network meta-analysis in adults. Adding the blue dots underneath the green dots, you can see that there's generally similar effect size, with some differences. Lurazidone was stronger, but there was also treatment-resistant subgroup treated that had a larger effect. There was less efficacy with ziprasidone, which may have to do with the weight-based dosing or with non-adherence in that study. And there was slightly higher effect size with the sedating drugs, olanzapine and quetiapine, where maybe the sedation was seen as efficacy because the total PANSS was reduced. Bottom line, antipsychotics work for people with psychosis, in this case schizophrenia, whether they're adolescents 13 to 17 or adults 18 and above. A little bit more fine-grained, we saw that total and positive symptoms were comparable among antipsychotics, except for ziprasidone, which was inferior to several antipsychotics. All antipsychotics were better than placebo except ziprasidone and asenapine. Olanzapine did have an edge on CGI, the overall global impression, versus aripiprazole, asenapine, paliperidone, quetiapine, risperidone, and ziprasidone. But again, it's hard to not unblind olanzapine due to the heavy weight gain, which makes it more of a third-line treatment before people go to clozapine. There was no efficacy difference among antipsychotics, including olanzapine, regarding response rate, depressive symptoms, or global or social functioning. Looking at a different meta-analysis that took lurazidone as the treatment reference, you can see that all-cause discontinuation, which is a measure of acceptability, was similar between all antipsychotics, with the exception of less acceptability, which is more dropouts with aripiprazole and paliperidone. Clozapine looked a little bit better here, but had a very large effect size confidence interval. But again, mixing in treatment resistant with non-resistant patients may be problematic. But this was also done in this network meta-analysis, where you see that clozapine only hinged very limitedly in this network, being only connected to haloperidol and olanzapine, the three trials that I showed to you earlier. This is a large table. I'll walk you through it. In blue, you can see efficacy, that is change in total PANSS. And in the red bar here, you see the difference compared to placebo. And you can see that all agents, with the exception of haloperidol, trifluoperazine, loxapine, and ziprasidone, separated from placebo. In this network meta-analysis, asenapine also separated. The biggest effect size was seen for clozapine with 1.6 standard deviations difference. Then olanzapine and molindone, as well as risperidone, had respectable effect sizes, but all of them between 0.38 and 0.74, with overlapping effect sizes without drug-drug differences. Looking at all-cause discontinuation, the drugs that led to less discontinuation, where placebo had a higher rate, was with paliperidone versus risperidone, olanzapine barely, and also there was, those are the three agents. The rest was a mistake in the paper. It shouldn't have been bolded. Other than that, there's at least no higher dropout with any of these agents compared to placebo, showing again their overall acceptability. As we have it in our guideline at the moment, and here are the 4 papers that we were able to contribute, that is the current evidence on early response predicting later response, and the reverse is true, early non-response at least 2 or with aripiprazole 3 weeks of good dose treatment, when you see nothing, not even minimal improvement, either that is less than 20% total PANSS change, or we've already checked this in one study just with the clinical global impression scale, less than minimally improved. And in the most recent paper in Press in the JCAP journal, again, CGI less than minimally improved, performed almost as well as the PANSS score-based early non-response, telling us that this is clinically valid and also scalable, because we can estimate less than minimal improvement at 2 or 3 weeks after good dosing. Then we may need to move on to the next treatment. But what about maintenance treatment? This is currently in the world literature the only randomized withdrawal trial, which is standard in the approval process with antipsychotics in adults, where stabilized patients are either maintained on the antipsychotic or switched off to placebo. This was done here with aripiprazole, and hands down, significantly better outcome in people who continue treatment with the antipsychotic. The overall number needed to treat was 7, But you can also see doctors, patients, and families were able to find the right dose during the stabilization phase, that those patients on 20 to 30 milligrams had a significantly better NNT of 4 compared to the lower dose of 10 to 15 milligrams. So again, you want to titrate to the optimal dose of the patient that they need, and then continue that dose, as we've been recently able to show in a Lancet Psychiatry paper. Mikkel Højlund is the first author, in adults at least, that lowering the dose below standard dosing may lead to higher relapses. But what about outcomes longer than a year? Here, a study, open label, with lurasidone, showing that patients stabilized even further over time. But mean scores are not that telling. What about subgroups? Here we looked at responders in blue, where open label baseline was after 6 weeks of the randomized treatment. Here already 63% had a response, which was only 20% of improvement on the total PANSS, which is at least minimally improved. That increased to 91%. But what about remission? Remission being coded as no more than mild positive symptoms, 4 of them, and no more than mild negative symptoms, 4 other important ones. And here, only 40% at 6 weeks, but then 2/3 of the patients, 2 out of 3, were remitted as early as month 6, and that was maintained throughout the 2 years. Here again, the treatment-naive patients did far better than those that were previously treated. 100% were at least minimally improved versus 90, and 81 to 76% were in full remission at 1 and 2 years, compared to about half, telling us again that we need to avoid and prevent the second relapse. And here, it wasn't a remission, my apologies, the pink, the lilac bar is actually a 50% reduction, which we consider much or very much improved. That generally translates into pretty good remitter status. What is also in the guideline is, although there's no randomized study in children and adolescents, long-acting injectables could and should be considered. And this is our largest meta-analysis on this topic in adults, almost 400,000 patients, 32 randomized trials, 65 cohort studies where clinicians choose which agent do they give to the patient, and 40 mirror image or pre-post studies, showing that in each design, significant advantages for the long-acting versus the oral treatment, because adherence is more assured, and we see when a patient becomes non-adherent. But we also looked at 328 other outcomes than hospitalization or relapse, and finding that in 1 out of 5 almost, the LAI was superior to the oral treatment, and in none of the efficacy or effectiveness outcomes did oral beat LAI, but it was the other way around. The 5% advantage of the LAI, that was a spurious finding that we're following up with another meta-analysis, because for side effect outcomes, there was only 1 LAI to compare against with many of other chosen orals in many studies. And that biased the outcome, disfavoring 1 LAI that had potentially 1 significant side effect more than the mix of the others. But again, no RCTs in kids, although the FDA now allows extrapolation and wants sponsors to include people age 13 and upwards in LAI trials in order to glean some data that can then be combined with open label and PK data to give approval in the future. Let's finish up with tolerability. We can't talk about efficacy alone. Drugs also need to be tolerable. It's hard to compare directly the outcome in children and adolescents versus adults, because very few studies actually combine the samples in one. But when counting side effects in similar trials, we were able to show that kids seem to be at higher risk for sedation. They looked at higher risk for Parkinsonism, but that was due to faster dosing and first-generation agents. In a large cohort study we conducted, when dosed appropriately and titration was built in, there was no higher Parkinsonism with second-generation agents in youth compared to adults. Higher risk of withdrawal dyskinesia, prolactin elevation and related side effects, particularly in post-pubertal females, and greater sensitivity to weight gain and dyslipidemia, because often patients are treatment naive. There's a higher likelihood to still gain weight. And in adults, they already start at a higher level. There was a lower signal for persistent tardive dyskinesia and diabetes, but these are long-term effects that are also dependent on cumulative dose and time. Here, again, a network meta-analysis comparing lurazidone against other agents, showing that the EPS rate was comparable across agents and no different from placebo. Note that paliperidone is not in here, that in another network meta-analysis I'll show you had a clearer signal for anti-Parkinsonian medications being given without a difference among other agents. Akathisia, again, no difference between the agents with data, asenapine, paliperidone, aripiprazole, ziprasidone, or lurazidone as the reference, but all of them slightly more restlessness than on placebo. Looking at the big meta-analysis, including clozapine, here in blue we have sedation and in red anti-Parkinsonian drugs. So let's start with that. And as I mentioned to you before, against placebo, the only drug that had a significantly higher rate was with paliperidone. And there was also a difference of higher akathisia with aripiprazole versus quetiapine, but based on just one study. Looking at sedation, all antipsychotics except for lurazidone and the first-generation agent fluphenazine, as well as quetiapine, were more sedating. Interestingly, quetiapine at lower doses didn't seem to be more sedating than placebo, but risperidone, aripiprazole, haloperidol, olanzapine, loxapine, paliperidone, asenapine, and clozapine, all more sedating. And the further down you go, the more sedation you see, clozapine being the most sedating agent. Looking at prolactin increase as another antidopaminergic side effect, here we can see that several medications had higher prolactin elevations than placebo, including even quetiapine and olanzapine, that in adults would not really do that. Also paliperidone, haloperidol, and very much so risperidone. Looking at weight gain in blue, on the other hand, we can see that several medications have significant weight gain, the most with olanzapine, even more than quetiapine and clozapine. Then further down, we have paliperidone and risperidone. Less so asenapine and aripiprazole, and no significant difference for fluphenazine as well as lurazidone, which was weight neutral compared to placebo in short-term trials. Looking at this also in a meta-analysis where lurazidone in a network meta-analysis was the reference, we can see that all antipsychotics had higher weight gain in adolescents with schizophrenia, except for ziprasidone and aripiprazole, at least in this meta-analysis, and clozapine, which had a wide range. But here, less data were considered. We do know that weight gain, unfortunately, is quite large, particularly in treatment-naive patients, like in this study that we published a while back. But we also showed that weight gain doesn't translate into metabolic parameters being deranged to the same degree. Olanzapine followed by quetiapine had the greatest signal. Olanzapine for all glucose metabolism and lipid metabolism markers, quetiapine for all lipid metabolism markers. Risperidone isolated for triglycerides, and aripiprazole, despite 4.5 kilograms of weight gain over 12 weeks, being metabolically quite neutral. So we need to monitor both weight and metabolic separately because there may be different, even weight-independent effects with some agents. Quite interestingly, in the 2-year study with lurasidone, the overall weight gain was actually below the expected weight gain based on the trajectory of growth. It was 4.9 kilograms compared to the expected 5.7 kilograms. And that is although about 20% were antipsychotic naive, where we would see more weight gain, but that wasn't really seen much there either. And some of the lower weight gain might be due to the fact that people had gained weight on prior treatment. What about diabetes? It's not as common as in adults, but we were able to show in a meta-analysis of cohort studies that yes, antipsychotic treated youth can have more diabetes than control youth, either in the general population, which is 3-fold higher. But if you look at psychiatrically ill patients who have background unhealthy lifestyle behavior, but are not on antipsychotics, the diabetes risk is still 1.5 to 2-fold higher, with the highest risk that was identifiable, again, with olanzapine. Finally, what do we do when we have weight gain and metabolic abnormalities? And here the IMPACT study, NIMH funded, was quite helpful for us to look at 8 to 19-year-olds, people with schizophrenia spectrum, but also other spectrum disorders who were overweight or obese and were randomized to either healthy lifestyle instruction as our control, added to the antipsychotic, or added to that metformin, or a switch to a lower risk agent. And we were able to show that metformin addition or switching to a lower risk agent were both significantly superior to just healthy lifestyle instruction, where people continued to gain weight, whereas there was some developmental weight loss. People grew and didn't gain much more weight, and therefore had an improvement in their metabolic parameters. Other adult tested evaluations and interventions for cardiometabolic side effects include individual lifestyle counseling, exercise intervention, psychoeducation, but these work in those patients who are actually motivated to go into the study. Then we have topiramate and metformin as 2 treatments where metformin has also now been validated in children and adolescents, and most other treatments not really having good evidence for improving cardiometabolic outcomes. Final slide before the conclusions. Here, an umbrella review looking at 78 reported adverse effects in 80 psychotropic drugs, focused here on the 15 antipsychotics, looking at which side effects are actually reported on. And you can see there are many antipsychotics where there's very little reporting of side effects. That is the overall bar. But then looking at the percent of side effects that were significantly more frequent than in placebo, we can see that actually lurasidone has the best profile of having only 1.3% of the 42% even reported side effects being significantly greater than with placebo, followed by arsenipine, ziprasidone, paliperidone, quetiapine, aripiprazole. Obviously, side effects need to be evaluated one by one, and this only gives you frequency and not severity or impact on functioning. So let me conclude. Schizophrenia, as we all know from our daily treatment, is a severe disorder that often has a debilitating course requiring clearly timely diagnosis and treatment. Longer duration of untreated psychosis needs to be tackled by better diagnosis and more timely treatment. Baseline psychopathology, social dysfunction, substance abuse, and depression can all contribute to poor outcomes and should be treatment targets. Efficacy differences, except for clozapine and treatment-resistant patients, are much smaller and less predictable than side effect differences that are much larger and more predictable based on the pharmacology. Since we don't have reliable intra-individual response predictors except for early non-response at 2 to 3 weeks of a good dose, where you see almost nothing moving, here we need to tailor patient characteristics and needs to the medications, but particularly side effects. And we need to bear in mind quality of life and functionality as clear targets of treatment. Pediatric patients are at higher risk than adults for prolactin elevation, sedation, weight gain, metabolic effects, and we need to monitor and manage these risks that have serious potential future implications. We need to have better drug development for safer drugs that are not postsynaptic dopamine blockers that are actually under development right now, and also focus on brain development and long-term efficacy and tolerability. Thank you for your attention. I look forward to the further discussion.